everyone, and welcome to today's podcast. We have Kathrine Issitt, the health visitor for City of London and Hackney. Welcome to Kathrine.
Hello, thank you, Verity. Yeah, I'm a health visitor working in the city in Hackney. Just as a background, health visitors are registered nurses or midwives with additional training in public health, and we work with families from pregnancy up until the child is 5 years old. The service forms part of the Healthy Child programme, providing screening, health promotion, health needs assessment and child's development reviews. In the city in Hackney, we work autonomously as part of the enhanced health visiting service, managing a designated caseload of children and families in order to improve child health and enable them to reach their full potential.
So can you tell us a little more about your typical day? What does that look like?
Yeah, it's quite mixed, but a typical day involves a mix of home visits, clinic appointments, liaison with other agencies, for example, GPs, social workers, midwives, medical staff in the neonatal and paediatric wards, also the infant feeding team and the perinatal mental health team. We're also, in the morning, perhaps would start with writing reports, attending child protection meetings, and we also support nurses in their general training, postgraduate nurses, and also we have health visitor students, so they're often with us, shadowing us. The morning would also be part of responding to emails, messages from both parents and professionals, and also text messages from parents. We'd go through and review records for scheduled contacts and planned visits, updating records from correspondence or visits. And then during the visits, we'd perhaps visit a newborn baby, when we do that between 10 and 14 days old. This is carried out at home, providing a health review, assessment of needs, advice and support on feeding, including breast or bottle feeding, a newborn examination and recording of weight and height of the child. Health promotion topics that we discuss during this contact would be reducing the risk of sudden infant death syndrome, including safer sleeping, immunisations, developmental milestones, brain development, accessing local services, including the children's centres. And we signpost parents to the infant feeding clinics. Also, we talk about managing common childhood illnesses, discussions around perinatal mental health, assessing for low mood, depression and anxiety. So that would be a new birth visit. We also would do developmental reviews again at 4 weeks if it's a first-time mum, 6 weeks, a 3 to 4 month review for targeted clients, an 8 to 10 month review, 27 months. And for some children, we're just starting a 3 to 3.5 year review. We also run child health clinics, and we do those in GP surgeries, health centres, and children's centres. Parents can access these clinics for advice and support with feeding, starting solids, sleep, childhood illnesses, any concerns regarding growth, speech and language development. And we also support families who require additional support, for example, parents who are victims of domestic abuse, depression, or if they're child protection concerns. So that's pretty much what a day would be like, give or take a little bit.
That sounds really busy. Can you share some common challenges that you face in this role?
A significant challenge is building trust with families, especially if they're safeguarding concerns. Often we're the first to notice signs of neglect, abuse or domestic violence, and we need to support the families getting the right support. Safeguarding cases can be quite complex and difficult to navigate, but building a relationship with families and being transparent is vital. It can also be challenging, sometimes managing a caseload with a high number of families, which require ongoing additional support, together with meeting KPIs for developmental reviews, home visits, whilst handling unexpected or urgent cases. Also supporting families with complex needs, for example, homelessness, living in hostels and hotels, or families who have no recourse to public funds, families living in poverty, or homes that are damp or overcrowded. For example, children not having their own space to sleep, not having their own beds, or if there's substance misuse or debt. Communication gaps between agencies can delay interventions and affect outcomes for families, and resources not being available for all can be upsetting for families. I think with all of us, documentation and record keeping are essential but take up valuable time away from direct interaction with families.
You mentioned child development. How do you assess that?
A development review takes place with the child, obviously the child and the parent, and some nurseries also participate in the integrated reviews for the 27-month review, so that the key work is included in that review. The reviews can take place in a nursery if a child's attending one, at home, in a children's centre, GP surgery. We're always taking feedback from the nursery, the parents, their observations are also always taken into consideration. So we assess the child's physical development, for example, the gross motor skills, their growth, their weight bearing, standing, walking, fine motor skills, for example, hand-eye coordination, say for an 8-month-old, if they're passing from hand to hand, whether they've got an immature or mature pincer grasp. Communication skills for a younger child, whether they're babbling and using their voice, engaging in conversation. For an older child, it's their ability to follow instructions, using words and starting to form sentences. We use developmental reviews, assessment sheets, the ASQ, and also a tool called ELIM, which helps us assess their speech and language development. We're looking at hearing and vision, observing for a squint or any family history of early vision or hearing problems. And then we obviously can refer them on if they need further investigations. Social and emotional development, looking at the child's play and interaction with parents and others, their emotional responses, their ability to self-soothe and regulate their emotions. We observe for imaginative play in an older child, asking parents about the child's temperament and behaviour in social settings. A cognitive development would be looking at their attention span and memory. For example, an older child, their ability to build a tower of blocks, complete a simple shape puzzle, drawing skills, colour matching, those sorts of things. And then also with an older child, their self-care, for example, their ability to feed themselves, dress themselves, dental care, how toilet training is going. So, like I mentioned, the ASQ questionnaire, parents complete that prior to the contact, and then they bring that along and it's discussed together. But with the 8 to 10 month review, that's through discussion with parents. They don't have a sort of prior questionnaire for that.
Do you have any advice that you could give to parents who might be listening about child development and how they can support their child in reaching milestones?
Yeah, we offer practical advice, when we first meet the parents to support their child with a sort of early development and milestones. But it often, it does start when the baby's newborn at that first visit, talking to parents how important it is to respond to baby's cries and to see the baby as, as an own little person. And also to be able to help build a secure attachment by picking up signals and also the baby's cues, the importance of skin-to-skin contact, lots of talking, singing, smiling, interacting to enhance their brain development. Tummy time can be started when the baby's very young, offering age-appropriate books, toys, mobiles when they're younger, keeping the baby close to them to offer reassurance. And short periods of time spent on the floor with mobiles, play gyms, those sorts of things, and maybe short periods in a chair for change of scenery. And to interact, engage with other children if they can, especially as they start to get older, starting attending groups and things at the children's centres, the libraries, limiting screen time and focus on face-to-face interaction. And with an older child, managing emotions, for example, I can see that you're feeling upset when a child's sort of starting to get upset or distressed, and recognising their emotions. Talking about distraction and modelling positive behaviour by showing kindness, sharing and empathy. We talk about routines, providing a consistent routine and, for example, a good bedtime routine. We encourage independence with feeding themselves, using cups and utensils, support self-care, start toilet training when the child shows readiness, getting them ready for school, for example, them to be able to dress themselves, wash their hands, put their toys away with help. But also to emphasise to parents that children develop at their own pace, but should generally follow key milestones. Early intervention is key if delays are identified.
Thank you so much, Kathrine. You've provided us with a wealth of information today. Everyone else, we hope you found this podcast really useful. Remember to look out for the Coldtail Top Tips on social media at Square Mile Families. And we look forward to another informative podcast next time. See you all soon. Bye.